Hello, everyone. Thank you for joining us for the third session of the ISPD virtual education series. Today will be our first debate. Fetuses with non-isolated fetal anomalies or genetic syndrome should be excluded from fetal therapy. Magdalene Cortez will be presenting the argument for, and Paige Church will be presenting the argument against. The format for our debate will be an introduction and initial poll of the audience, followed by the for and against arguments. We will then have some time for live Q&A from the audience before each of the debaters will give their rebuttal. We'll then close out the debate with a final poll of the audience again. Before we get started, I have a few announcements. If you need technical assistance, please use the chat function for support. The presenters have pre-recorded their initial statements, but throughout the broadcast, you can submit questions for the presenters in the Q&A function, and we'll address these during the Q&A section. You can use the thumbs up button to vote for a question that you like the most, which will push it higher up in the questions list. You can also raise your hand to speak, and if we have time, the moderator may call on you. The statements expressed by the presenters are those of the participants individually and do not represent the opinion or position of the International Society for Prenatal Diagnosis. This event's being recorded, so if you do not wish to be recorded, please don't raise your hand to speak or submit a question in the Q&A. So to set the stage for the debate, we're going to start it off with a poll. So you should see a poll appearing on your screen right now. And this is just, should fetuses with non-isolated fetal anomalies or genetic syndromes be excluded from fetal therapy? So we'll give everyone just a little bit of time to fill out this poll. All right, still have some responses coming in, so we're going to give it just a bit longer. All right, I'm going to go ahead and end polling, and we're going to share the results. So right now, 64% are saying no, that they should not be excluded, and 36% are saying yes. So setting the stage for a very interesting debate. And with that, I am going to pass things over to our moderator for today, Jan de Prest.
Thank you very much, Paige, for this introduction and this welcome to your weekly virtual education session offered to you by the ISPD. I have the pleasure to moderate this debate on fetal surgery, on whether one can actually stretch the indications, and if so, how far. I would like to remind you that the conditions under which fetal surgery is done are very precise and were defined by the International Fetal Medicine and Surgery Society a long time ago. And the number of conditions, obstetrical in nature or congenital anomalies, most of them lethal, are currently accepted or investigational indications for fetal surgery. Of course, when there are associated malformations, usually the natural course of the condition changes. I have to remind you that this was really a landmark study, not only because it was a properly done randomized clinical trial in fetal surgery, but it was also adding a new condition to the list, the first non-lethal condition eligible for fetal surgery. That trial demonstrated that there was a certain neuroprotection by the prenatal intervention. Babies that had undergo in utero surgery were less likely to have a shunt placed within the first year of life. They were more likely to ambulate, and this was measured at 2.5 years. And overall, they have a function gain of around 2 levels. Also, more recently, their bladder function has been shown to be improved. Of course, this was a single randomized trial. At the meta-analytical level, a other study in Poland, a controlled study, showed the same results, and therefore we think that the level of evidence for this surgery is quite high. Obviously, this comes at a price. I mean, there is the problem of prematurity with quite a significant number of patients delivering prematurely adding a morbidity to this condition, which is not part of its natural course. Also, some maternal side effects. We should not forget that this operation puts the mother at a certain risk, both during the index pregnancy, but also in the subsequent pregnancy, at least if it is operated by hysterectomy. This gave lead to a wider spread of fetal surgery, and many programs over the world are today active, and they are usually set up under inspiration of these innovators, and those innovators have defined the conditions under which you can set up such a program. But since, and as usual with new techniques, many centers have started to do this, but have changed their techniques. And that's one debate, not for today, but people have started changing the selection criteria. And this is what we're gonna discuss today. The real question is, if you have a new hammer, does everything that looks like a nail needs to be hammered on? I myself have been engaged in other surgical conditions, and it is not uncommon that we extend the indications to very selected patients that have, next to the condition that we operate for, also has another condition which may or may not independently influence the outcome. So I would like to present you my dilemma in 2014, 2 years far in our program, where we had a typical case presenting at around 24 weeks, a lesion that on itself was certainly illegible, no ventriculomegaly, an L3 lesion with conserved lower limb motion. So a real ideal candidate in a slim patient without any risk factors. But during the scanning, we found an associated cleft lip, and in the presence of a normal genetic findings, but indeed there was a family history of cleft lips, and for those parents, this was definitely not a reason not to ask for us to operate. So the question is today, what do we tell such parents? What are we telling them when they ask us this, when they are confronted with this situation? Today, the motion for will be by Dr. Magdalena Sanz, and the motion against will by Dr. Paige Church. They're both very well placed. I mean, Dr. Sanz is an associate professor in Houston at Baylor College of Medicine. She's a maternal fetal medicine specialist who had her training in Europe, did a PhD in Barcelona, and then is now a consultant at Houston Hospital. She has a special interest in fetal interventions, in particular in spina bifida. She has a long-standing interest in fetal neurology and fetal neuroimaging. She's also a leading member of NAFNet. She has been a long-time chair for the fetal MRI focus group, and she is currently heading the fetoscopic repair consortium within ISOWOC. Dr. Paige Church is the medical director of the neonatal follow-up clinic at Sunnybrook Health Sciences Center in Toronto, in Canada. She's the lead for the spina bifida and spinal cord injury program at the Holland Blovium Kids Rehabilitation Hospital, and has a dual certificate. She's a neonatal perinatal medicine specialist, and as well as a specialist in developmental behavioral pediatrics. So I think we can have no better debaters than these. I would like to give them the floor now, and we will start off with the motion for Dr. Magda Sanz-Cortez.
Good morning and welcome to today's ISPD debate. I will be convincing you why fetuses with non-isolated fetal anomalies or genetic syndromes should be excluded from fetal therapy. My name is Magda Sanz-Cortez, and I'm a fetal surgeon at Texas Children's Hospital. First of all, I would like to disclose that the opinions presented in this session do not necessarily reflect my personal or institutional views, but the side that I was assigned to defend in this debate. Let's take a step back and let's think if all fetal therapies should be considered at the same level for patient selection. Does it sound right? Well, the answer is no. When we're thinking about performing a fetal surgery or intervention, all the possibilities are not aligned at the same level. We have to think how invasive the surgery is, the risks to the mother and the fetus, and the potential outcomes that we will be obtaining with the surgery, if we're intending to save the life of the baby or to improve the quality of life of the fetus. We also have to keep in mind the evidence that supports the indication or performance of such fetal intervention, if it's still on its experimental journey or if there's strong evidence backing it up. Since not all fetal therapies are aligned at the same level, we can group them based on the outcomes. Definitely, there's some of them that are going to be life-saving. Think about fetal cardiac interventions, or think about laser photocoagulation of the communicating vessels in twin-to-twin transfusion syndrome. We know that stage 2 or above, if left untreated, can lead to fetal demise in 90% of the cases in one or both babies. In another group are those therapies that have the potential to improve some vital functions, such as, for example, in congenital diaphragmatic hernia, treatment through Fetal. We expect that this type of surgery or intervention might improve the severity of lung hypoplasia that is typically seen in babies with congenital diaphragmatic hernia. In a third group are those that fetal surgery can improve the quality of life. And a good example of that is the in utero repair of spina bifida, since it is expected to preserve the motor function and decrease the chances of need for shunting. Since we're saying that not all fetal therapies should be at the same level, we should also consider how invasive they are. In one side of the spectrum are the needle ultrasound-guided surgeries, for example, for in utero blood transfusion indicated for fetal anemia. One step farther in the ladder of invasiveness would be the fetoscopic surgeries, such as, for example, laser for twin-to-twin transfusion syndrome. And at the very end side of the spectrum would be the open hysterotomy surgeries, such as, for example, an in utero resection of a sacrococcygeal teratoma, or more commonly, the open hysterotomy spina bifida repairs. The more invasive that we are in the uterus, the more likely it will be to have certain complications. Just to make a comparison, if you perform an amnioreduction for twin-to-twin transfusion syndrome, chances that you will have PPROM in the subsequent month would be 9%. However, if you perform an open hysterotomy for spina bifida repair, chances that you will have PPROM will be 46%, and 13% of those cases will deliver at less than 30 weeks. So not one size fits all when we're talking about fetal therapies, but I would like to restrict the remaining minutes of my presentation, especially to those therapies that are not life-saving, and especially those that are not extremely minimally invasive. In those type of surgeries are the ones we are going to have the following considerations that I will be presenting. So I will be presenting 5 reasons why non-isolated fetal anomalies should not be considered for fetal therapy. First reason is that it just goes against the principles of fetal surgery. Here listed these principles that are adapted from Harrison in 1991 and endorsed by the International Fetal Medicine and Surgery Society. First principle is to have a correct and precise prenatal diagnosis. And second principle is exactly what I'm defending today in this debate, to have an absence of an associated anomaly. Third principle is to have good knowledge of the natural history and prognosis, to have an absence of an effective neonatal therapy, and to have animal study data showing favorable results reversing deleterious effects of the condition. It should be performed in specialized centers with a multidisciplinary approach, and it should not compromise the reproductive future of the pregnant patient, and of course, should not increase maternal mortality. The second reason I will be giving you to defend my concept, which is that non-isolated fetal conditions should not be considered for fetal therapy, is that we might induce maternal morbidity for unknown benefits to the fetus. So if the fetus presents with genetic or structural abnormalities linked to a poor prognosis, fetal therapy likely will not change the poor prognosis, but in fact, it might increase maternal morbidity. And the increase in this maternal morbidity could be affecting the index pregnancy, as was shown by mom's trial, that the arm that received an in utero spina bifida repair through an open hysterotomy presented with different degrees of maternal complications such as pulmonary edema, placental abruption, core immunitis, and need for blood transfusion after the time of delivery, ranging from 3% to 9% of the cases. Moldenhauer et al. Published their experience on 100 cases that underwent an open hysterotomy spina bifida repair in the post-MOMS trial era, and they showed that these complications still existed, however, to a lesser extent. But more importantly is the status of the hysterotomy site at the time of delivery. MOMS trial showed how 9% of the cases who underwent an in utero spina bifida repair through an open hysterotomy presented a clear area of dehiscence, and 25% of them presented areas of thinning. These results were very similar to what was published later on by Moldenhauer et al. We also have to keep in mind that the rate of perinatal death is there. There's 3% of the cases that died in utero or in the neonatal period reported in the MOMS trial, and this rate was 6% by Moldenhauer et al. So maternal morbidity is something definitely to keep in mind in the index pregnancy, but recently it has been published that it might affect even in the subsequent pregnancies. And this data comes from NAFTA group, showing how in subsequent pregnancies after an open hysterotomy spina bifida repair, they were able to see how patients had uterine rupture at the incision site in up to 10% of the cases, with the possibility of fetal demise when uterine rupture was present. These moms also had an increased need for blood transfusion at the time of delivery in up to 8% of the cases. Now, the third reason that I will be using is that if an intervention for fetal benefit is approved as innovation or research, variables should always be kept to a minimum. Changes in inclusion criteria will prevent us from understanding the benefits of the surgery. There is a tenet of Kantian morality that says a being is never to be used solely as a means to an end, rather as an end unto themselves. Any patient in an experimental procedure is being used as a mean to an end. This end is the generalizable knowledge instead of an end unto themselves. So we will not be able to obtain level 1 evidence demonstrating that experimental procedure can provide therapeutic benefit unless we do large and evidence providing type of studies such as randomized controlled trials. And this is still one of the Achilles heel of the fetal surgery research field, since it is very hard to obtain high quality evidence. And this is mainly due to 3 reasons. The indications for fetal therapy, the conditions that we treat, are typically very uncommon. So commonly, it is important to conduct these type of studies in multi-center fashion or international groups. Secondly, it is common that these patients, when they receive the news that there's an abnormality that is linked to a poor prognosis, parents decide to undergo a termination of pregnancies. And finally, there are some fetal centers or physicians who think that they do not have equipoise in order to participate in a randomized controlled trial based on the results from small observational studies that might provide information showing that performing an intervention is superior than doing nothing. So at this point, we can say that there's weak evidence, so we don't have so many randomized controlled trial data, proving the benefit of the majority of the fetal interventions that are currently offered in the fetal centers around the world. There are 2 exceptions. One is for twin-to-twin transfusion syndrome. In 2004, it was published how performing laser for TTTS was better than doing an amnion reduction. And for spina bifida, in 2011, it was published in the MOMS trial how performing an in utero open hysterotomy spina bifida repair was superior than having a postnatal repair, as it provided significant benefits to the baby, such as decreasing the need for shunting during the first year of life and increasing the chances of the baby being able to ambulate independently by 30 months of age. So here's a good example in the Pluto trial of why level 1 evidence is difficult to obtain in fetal surgery. This study was performed in an international group, and they were only able to recruit 31 patients diagnosed with fetal lower urinary tract obstruction. Out of those 31 patients, 15 were assigned to the conservative arm and 16 were assigned to receiving a shunt. The conclusion of the study was that the survival seemed to be higher in the fetuses receiving vesicoamniotic shunt, but the size and direction of the effect remain uncertain, such that benefit could not be conclusively proven. If we look into the inclusion and exclusion criteria of well-designed and conducted studies in our field, such as the MOMS trial, it was listed that having a normal karyotype was one of the inclusion criteria, and having an associated fetal anomaly was one of the exclusion criteria. So if an intervention is well established, expansion to include fetuses with such anomalies should be performed as approved innovation or research. Given the rarity of these anomalies, approved research will have to be multi-center and likely will require years to test the hypothesis. Now, let me give you a fourth reason to defend my line. Non-isolated anomalies can present with worse outcomes regardless of the intervention. And in fact, if we're performing a fetal intervention, we can induce preterm birth, which can worsen the outcomes. Here are the results of our fetal cases performed at Texas Children's Hospital, divided if the congenital diaphragmatic hernia was detected isolated or non-isolated. We saw that the non-isolated CD8 that received fetal showed a significantly higher need for ECMO and a significantly lower survival at the time of discharge. Similarly, Turner syndrome patients that are diagnosed with a congenital heart disease have a lower survival than those cases who have the same type of cardiac abnormality that receive the same type of cardiac surgery but have a normal chromosome. And finally, as my fifth reason to convince you of non-isolated fetal conditions should be excluded from fetal therapy, is that the association of some structural abnormalities can be indicative of a syndrome, although it cannot be proven in utero. It is possible that when we have specific fetal condition that we think that might be a candidate for fetal surgery, but is presenting in association with maybe one or a few subtle fetal abnormalities, that might be the case of a syndromic baby, and we are limited in our imaging in utero to detect whether if that's the case or not. We might just be seeing the tip of the iceberg. Think about apparently mild isolated ventriculomegalies. In this study, it was shown how when it was detected in expert hands by neurosonography, even in those situations, in 5% of the cases, fetal MRI was able to obtain significant CNS abnormalities in 5% of the cases. In those cases that were presenting as apparently mild isolated ventriculomegalies by neurosonography and also by fetal MRI, 4% of the cases presented with significant CNS abnormalities detected by postnatal MRI or ultrasound. Thanks to the current extensive genetic testing strategies, it is now known that we can identify a genetic cause in up to 30% of the cases with non-isolated CDH, which sometimes might change the course or impact the prognosis of these cases. So as fetal surgeons and as the physicians who are working in a multidisciplinary group in a fetal center that offers different fetal intervention procedures, we would have to determine when is it time to draw the line and how much is too much. We have to weigh in the risks and the benefits for the mother and for the fetus. And we will have to keep in mind that being able to perform a surgery does not mean that it's always the right thing to do for the mother and for the fetus. And I would like to acknowledge some of the partners that I have in my hospital that have helped me out consulting for this presentation. And I would like to thank you for your attention. I'm happy to take any questions.
Hi there. Thank you for this opportunity to present a different perspective on this important topic of in utero closure. And I titled this approach, Time to Open Up, the Argument for Less Restrictive in Utero Closure Criteria. To review, the Spina Bifida Association published its first guidelines on prenatal counseling with the necessary components being 4 essential choices. Number 1 was an option of in utero closure. Number 2, postnatal closure. Number 3, termination. of the pregnancy, and number 4, adoption. I have added the circle here as I'm not going to focus on those pregnancies that were not going to be continued, but rather those pregnancies that had an interest in continuing the pregnancy and seeking options for their baby. In general, to date, the criteria for in utero closure has remained fairly consistent with that was set by the MOMS trial. And that generally includes women were eligible if they were relatively healthy, had a favorable uterus from a surgical standpoint, had experienced few, if any, significant intra-abdominal procedures, and were carrying a fetus that was unaffected or only affected by the neural tube defect and mild or moderate ventriculomegaly. The presence of a fetus with other anomalies was not deemed a candidate. And this made sense in the context of a large trial that needed to be rigorous and control for confounders. So today I'm going to argue, however, that the option of in utero closure should be expanded based on the following principles. Number 1, individualizing the assessment of the case and the findings. Number 2, the right of a woman to have autonomy in her choices. Number 3, the concept of beneficence. And number 4, resource utilization. Let me expand further. First and foremost, I want to make it clear, I am not in favor of every child now being given the option of having an in utero closure that has an open neural tube defect. But like many other conditions in medicine, I do think that there needs to be a case-by-case review and then an assessment and a decision. Specifically, I would not recommend that these children undergo in utero closure should they have additional findings that present with known neurocognitive impacts, such as, for example, lissencephaly, massive ventriculomegaly, or a child with profound congenital cardiac disease. In addition, I would say that this option is available for those families that have been well counseled on the lifespan experience of individuals with spina bifida and the family experience of those individuals. And they've already expressed that they are not interested in termination of pregnancy, as that would be a whole different way to go. The second principle is that all women, and really all patients, have the right to self-determination. And the act is acknowledged, or this principle is acknowledged when we get informed consent. We provide a balanced review of what is known about the procedure or the intervention, what is the risk, and what are the potential benefits. And through this act, we then initiate the process of shared decision-making. Shared decision-making has been described as the ideal approach when the evidence is less clear. But then it comes down to what is in the best interest of the child and the mother. And in traditional medicine, we have always used the markers of survival and the potential for disability as markers. So when you look at the data around this intervention, in terms of survival for the mother or the infant, there was no difference between those who were prenatally closed and the infants that had postnatal closure. What we do know is that the early data, meaning the data that was available when these children were still toddlers, was that those children undergoing a prenatal closure did experience a more premature birth, being born at 34 weeks versus 37 weeks. But the children who underwent the in utero closure were less likely to need a shunt. So postnatal closure and the traditional rate of shunting for children with an open neural tube defect is around 82 to 85%. This decreased to 40% with those children closed in utero. Cognitively, on early assessments, there was no difference, but for those children that were closed in utero, there was a significant impact of that they were more likely to be independently ambulatory. Looking at longer term data, this is from a recent paper by Amy Houtro and her colleagues around the 10-year outcome for these children that have had prenatal closure. What we see is that the likelihood of needing a shunt remains fairly stable across the lifespan, so that not many children who were not shunted within the first year or two have since been shunted. So the hydrocephalus needing a shunt is at 49% versus 85%. The need for a revision is obviously lower because less of these children had a shunt, and it appears that those who did seem to have a less complicated shunt presentation, and their ability to be independently ambulatory remained consistent, that they were more likely to be independently ambulatory. And then we get into this idea of, so we've talked about the evidence documenting that surgical closure in utero has a benefit, as it decreases the need for shunting, increases the possibility that these children will ambulate, and the gestation at 10 years did not seem to be a difference in terms of cognition or cognitive abilities. But what about the impact of the additional findings? So these additional findings that are found on ultrasound or on MRI may confer, for sure, an added degree of functional challenge. There's no question about that. But I would argue that the goal of this surgery is not to erase the disability, but rather to improve the function of the child living with the disability. And it is important to remember that decisions we make need to be with the whole picture in mind, rather than just focusing on an isolated or specific trait. Because, as so well said by Dr. Perrin and Dr. Ash, discrimination occurs when people in one group fail to imagine that people in some other group lead lives as rich and complex as their own. Everyone from literary theorists to bioethicists to obstetricians and genetic counselors are susceptible to such failures of imagination. And I worry if we start to look at a blanket statement of no, that we're not really imagining that their lives could be as rich as someone else's life. And I think that that's very important. Lastly, whenever there is not great evidence around a decision, obviously resource utilization comes into the picture. The graph on my left looks at the cost of in utero closure versus the cost of postnatal closure at the UNC in Chapel Hill, North Carolina. According to this review, the median prenatal surgery costs were significantly higher. They were $102,000 roughly, and that's this line here, whereas the median postnatal closure cost was lower at $55,000. And this was the joint cost of the mother's care and the infant's care for the first year of life. But when they looked at it statistically, there was such a range in cost that they really were not statistically significantly different. Regardless, that's only for the first year of life. And generally, if there is less likelihood that this population will need a shunt and a greater likelihood that this population will need a shunt, it is hard to say that the cost will not go up significantly for this population across a lifespan. When you look at the lifetime cost of myelomeningocele, and this is pre-MOMS trial data, so important to bear that in mind, but it is approximately $800,000. Medical costs for that were approximately $513,000. Then you start looking at what's the cost of a shunt and a shunt replacement, and I believe this is just the shunt, this is US data. It's approximately $3,300. So my point to you is this population is going to cost more money. Exactly how much, we don't know. Over a lifespan, living with a shunt and having the possibility of that shunt needing revision, with the greatest likelihood being in the first year or two of life, and then again in adolescence, and again in the mid-adult period. So in closing, what I want to leave you with is a quote from Dr. Ash, and I think that this is important for us to think about as we think about these mothers and fathers that are presenting to us, wanting to pursue an intervention that they think may help their child. In order to imagine bringing a disabled child into the world when abortion, or in this case termination, is possible, one must be also able to imagine saying to a child, I wanted you enough and I believed in who you could be, that I felt you could have a life that you would appreciate, even with the difficulties your disability causes. Thank you.
Thank you very much, Dr. Church. So we have heard both motions, and I will now look into the question and answers to both speakers, if both speakers can be available. Can I raise a question that comes from Afaf El Sheikh? We normally, for doing such procedures, we require prenatal testing, genetic testing probably. Some patients may refuse that, and may have their own reasons for doing that. Do you think it is ethical at all to even not offer prenatal testing prior to the surgery? Is that ethical or acceptable at all? Magda?
I think that it would not be adequate. It would not be good practice. If you don't perform the appropriate genetic testing, as is asking that question, we might take into the OR a mother who's expecting a baby that probably could have some kind of genetic disorder that is otherwise not being detected, or a chromosomal abnormality that could even have a potential for being a lethal abnormality. So what would be the reason for us to perform a very complex and risk-taken type of surgery to the mother for a baby that could have trisomy 18 or trisomy 13? So definitely all these mothers, if they want to embark themselves into a surgery like that, they should have genetic testing prior to surgery.
Thank you, Dr. Church.
So a few comments. One is that obviously I'm trying to stick to my line, although it's not very easy. I agree with Magda that it's hard when you're asked to stay in one box. The way I see it is that I think that the issue of whether or not to have prenatal testing is important. I think parents do have the right, but I think more importantly, the discussion around what the prenatal testing will disclose and the reasons for it needs to be reviewed very thoroughly, and perhaps in a way that isn't focusing on the necessary problems that the child is going to have, but instead focusing on it in a very lifespan perspective. And I agree with Magda, and I don't know if I'm allowed to, but that it is not ideal to take a woman to the operating room and do a significant surgery with variables that are unknown. I think that the importance of the prenatal testing, maybe instead of being initially put forward as an absolute gatekeeper, should be on information gathering to determine safety and benefit of the surgery, and start the conversation there. I think when it's presented as an absolute gatekeeper, families don't understand the variables, and it becomes a roadblock that perhaps is unnecessary.
But what if the patient ahead of time tells you, whatever the outcome of these tests is, for me, it doesn't matter in my decision making? These are the typical statements of parents in that scenario.
I think historically medicine has erred on the side of perhaps being a bit paternalistic, and I think parents do have a right to ask for their children to have the care that they want. While we may not be doing fetal surgery for trisomy 13 and 18, I can tell you in the pediatric world, we are offering interventions to give them more function and have their lives prolonged. And parents are reporting that that life is important and that the quality of that life is valued and valuable. So I think we underestimate the value that children, even with significant disabilities, can bring to their families. So I do think that they have some fairness. The hard part is you're talking about putting a woman through a surgery that has significant morbidities for her. So that discussion, I think, would take a lot longer to work through. But I do think they have rights, and I think it's an important discussion.
Jan, let me answer that question in presenting a potential situation, and that will give you the answer based on my opinion. If you take a patient to the OR on a baby just because the mom wants to do everything for their baby, and the baby has, let's say, trisomy 18 or a genetic disorder that is associated with a very, very compromised and poor prognosis, you do a spina bifida repair, and as we know, it can lead to a chorioamnionitis. The patient can end up in a chorioamnionitis. Patient can have a baby at 26 weeks. Baby might die, or because of the chorioamnionitis and preterm delivery at 26 weeks, or because of the genetic condition, and the mom can get very sick. And eventually, even the mom can end up with a hysterectomy, as has been reported by other groups that are performing advanced or more invasive type of fetal surgery. Would that make sense looking back? We're not trying to be paternalistic, but we are the ones as fetal surgeons and physicians that work in this field that we know the potential outcomes. If there's a situation like that and the mom, in the worst case scenario, would end up with a hysterectomy, or even worse, could die, it would be absolutely unethical to put the mom to so many risks and so many complications for a baby that unfortunately has a condition that might end up dying shortly after birth.
Thank you for that. Another question is along the line of combinations. I mean, we spoke about trisomy 18 and 13, and some associated malformations or conditions, genetic conditions, may not be that prominently influencing the outcome. So let us take another example, and that's a question that came from Holland, from Dr. Haak, and also from Dr. Lux in Rhode Island, is when we have the association of trisomy 21, and for instance, the occurrence of pleural effusions, Dr. Sanz clearly said the invasiveness of the procedure also plays a role, and shunting is a procedure of limited invasiveness. So can we do that? Should we do that? Along Dr. Church's lines is if we can alleviate the condition. I mean, this intervention may actually temper the effect of the effusion on lung development, on further pregnancy outcomes. So what would you do in such a scenario? What is your advice? I would ask Dr. Church first and then Dr. Sanz-Cortez.
All right, I just want to be sure I understand. So we're talking about shunting for pleural effusions. We're not talking about shunting.
No, shunting pleural effusions, trisomy 21 in utero still.
Yeah, so I think, again, it goes back to the importance of a very individualized and shared decision-making process where parents are given lifespan perspective of life with trisomy 21, potential challenges for the child, potential strengths for the child, the benefit potential of the intervention and the risk of the intervention. And then they should proceed with their decision being shared with the physician. I don't think it should necessarily be a physician-driven decision only. In terms of the potential benefit, I'm now wandering a little bit outside of my normal spina bifida expertise, but into neonatology. It is possible that they would have better lung development and that would serve them better across a functional lifespan. And I think that that is an important opportunity that families should have presented and should be a part of that decision-making. I don't think we should completely take it from them and say that it's not possible. And I think the lifespan of a child with trisomy 21 can be rich and complicated and colorful, and it's not going to be perfect, but many people say it's more perfect than anything we could ever imagine.
Dr. Sanz?
So as I said at the beginning of my talk, I think that we should make a differentiation between how invasive surgery is. If we're talking about placing a shunt, we're talking about basically needle ultrasound guided type of procedure that is putting at a very low risk to the mother. So I would have to take off the hat that I'm defending in this debate. And I would say that if the mom understands the risks and the benefits, if there's a multidisciplinary type of consultation with medical ethics, with genetics, fetal surgery, pediatric surgery, etc., and the entire team agrees that is the right option to do, I think that in those situations, it would be okay to have that type of intervention being offered in that situation.
So we are moving further along the same line of along the slippery slope. A question from Dr. Stover is, we have a baby with congenital diaphragmatic small lungs, investigational procedure, minimally invasive Pallister-Killian syndrome. So we have moved now a little bit more to the right. Is the answer to that question different? Dr. Sanz?
I think that Pallister-Killian is different just because, and when we're talking about fetal, there's also some risks that are not present when we're talking about placing a shunt. When we're talking about fetal, we're talking about potentially exposing the mom to the need for an exit. Of course, it will not be our first approach to remove the balloon, but definitely it's one of the therapeutic options or intervention to remove the balloon before birth. An exit could have some damage to the uterus, and an exit also can entail a higher degree of bleeding, need for blood transfusion, etc. So it's not a risk-free type of intervention. And Pallister-Killian itself as a genetic syndrome is associated with a very poor prognosis. So my answer for this example that is being presented would be that in that situation, fetal should not be offered, and especially under the current situation that we're currently expecting the results of the total trial. And we don't have a high level of evidence that fetal actually improves the outcomes.
Dr. Church, different combination, different type of surgery?
It's a little bit harder for me to answer because I'm not the surgeon. So I don't know. I don't know if I have anything more specific than what Dr. Sanz-Cortez has already said. I mean, I think that sounds very reasonable, and I wouldn't argue.
I will come with the next case further down the line. This is spina bifida. As you know, we often see associated problems of which we don't really know the nature or the exact meaning, certainly intracranial findings. I always say we are just beginning to understand in utero this condition because we have a renewed interest in the condition. So even if we don't have genetic findings or associated structural problems, we often see things, subtle changes that are different. I mean, is it all a question of parental choice in that stage? Because we can only share our doubts about the prognosis. So is it really parental choice, or can we tell to patients that when we have the slightest doubt that this condition may have impact, so that we can deny these patients access to surgery for spina bifida, for instance? So where would you put, I mean, we did know easily today by saying it's an associated structural anomaly, but there are many things that we don't know the natural history from, also part of the spectrum. So is there for you a limit of indication, Dr. Page, Church?
Great. And Paige, am I still okay to go?
Yes, I just want to interject that we can do this question and then we'll want to move on to the rebuttals.
Okay,
Absolutely.
sorry. You know, I think it's important that we recognize that in medicine, we tend to see the problem list as a problem list. I mean, we identify it as a problem list. We see medical conditions as negative barriers or obstacles for families or children to carry. When you look at families' perspectives of children who have had spina bifida and have had the in utero closure or postnatal closure, but in this case, prenatal closure, many of them will talk about the fact that they found it was a positive, the child has been a positive impact on their lives. There are a whole host of cognitive challenges these children will run into, and it is very hard to predict what they will be and for whom. So one of the best minds was Dr. Dennis, and she talked about the one thing you could predict with spina bifida was the consistency of the inconsistency with the neurocognitive outcome. So we see children who I would expect to have a very typical learning profile, and I see challenges, and I see other children who I would expect to have more challenges have less challenges. So certainly that statement rings true. I think what's most important is that families be offered the information in a value neutral way. So we're not assigning I have my own biases about what I would or would not want for my family, but we're not offering those. I have important news, not bad news. This presentation may present with significant challenges, not bad challenges, not severe challenges, just significant. And then you describe them, and you describe them. May need to be in a special classroom, may need a special teacher to teach math or science, maybe in a classroom with less children. You know, you describe the range. And if at the end of that discussion, may ride a special school bus, if at the end of that, they say, I wanted this life and I am not wedded to what that life was going to be, then I do think it is our ethical responsibility to minimize the morbidity and optimize the function as early as humanly possible. And if the surgery offers that and there isn't overt contraindications, meaning the mother isn't morbidly obese, it isn't hard to get access to the uterus, the brain isn't already 25 millimeters in ventriculomegaly, then I think it's worth discussing and letting the parents participate in that decision and not taking it from them.
Dr. Sanz, to wrap up.
Yeah, so I think that it is our duty as physicians who work in this field to understand well the nature of the conditions that we're treating. So it is our duty to understand the potential associated abnormalities that can be present in the Chiari-2 malformation. in order to distinguish those from potentially associated CNS abnormalities that might just be coincidentally present. It is not an easy task because sometimes we have doubts about if these nodular heterotopia is just like in the context of PI2 or if it's something else. Definitely, it can be challenging, but multidisciplinary groups are made for that. But if this was, when we're talking about spina bifida, if this is a surgery that does not have important complications or morbidity to the mother, I would be happy to consider expanding the indications of in utero repair of spina bifida. However, we have to keep in mind that these are not risk-free conditions for the mother or even for the baby. We can induce prematurity. So we could be talking about a spina bifida baby that might be delivered at term if we don't do anything. And if we do the surgery, we might end up having a baby delivered very early at 27, 28 weeks, and we might induce preterm related complications just because we did not do the right case selection for surgery. So at this time, I would suggest that we all work on an evidence-based medicine type of approach. And what does evidence tells us? It tells us based on the mom's trial that there's some indications for surgery, there's some exclusion and inclusion criteria. And if we do so, we know that we have good level of evidence about what outcomes we will be expecting to have.
Thank you very much, Magdalena. I am apologizing to the 17 other questions that were left unanswered. I'm sure we can exchange further ideas about them and we can pass them over to the discussants. I would like now to give the floor again to Dr. Magdalena Sanz for a rebuttal from her side to the discussant, Dr. Paige Church.
Well, some of the things that I had in mind for this rebuttal have been already asked in the questions. So I don't want to be redundant, but I think that it's very important to work on evidence-based medicine type of approach. And what we know in our field, and especially when we're talking about spina bifida, is that our clinical standard is the mom's trial. And so we know that if we stick to the inclusion and exclusion criteria of the mom's trial, we know that we will be expecting certain benefits to the baby. If we get outside of the inclusion and exclusion criteria, that's not a high level evidence-based medicine. And so the expected results are really questionable. I don't know how a trisomy 21 baby with spina bifida will respond to the surgery. We know that based on the mom's trial, it was 3% perinatal death rate and it was 6% reported later by the CHOP group. So I don't know if there's any genetic condition that might respond poorer to this type of repair. I don't know if the healing in utero of these complex genetic disorders might have a different response than those babies that are completely normal, as was reported by the mom's trial and studies that have been published after that. So my recommendation would be to always work on what has been published already with randomized controlled trials. And if we want to expand the indications, maybe we should consider start doing other studies that can provide evidence for different and additional indications. I think I agree with Dr. Church about the principle of autonomy and beneficent to the patient, but we also have to keep in mind the non-maleficent principle. So we know that these surgeries can have some complications and morbidity to the mother. So we are the gatekeepers for these type of potential complications that can be appearing in them. So we have to be very honest, very mindful about these potential complications and do not expand our indications unnecessarily. So the other reason that I want to present this in my rebuttal statement is that Dr. Church said that not presenting associated additional neurocognitive, that if a baby presents abnormalities that might have an additional neurocognitive impact in those situations, then she would not include those patients as potential candidates for in utero surgery. But I would like to take a step back and think, how do we know that the associated abnormalities that we are seeing might not have an impact in the neurocognitive outcome of that baby? there's some syndromic babies, there's some genetic diseases that might not have a CNS malformation or abnormality. It might just be the combination of other subtle structural abnormalities that might be reflecting a complex genetic disorder, and that potentially after the baby is born could lead to a poor prognosis in that sense. So how do you know? How can you be absolutely certain? Well, for that reason, if we see some associated structural abnormalities, the line that I'm defending here is to stick to what we know that works and not expand in those cases because we just don't know how the baby will do afterwards. And finally, about the resource utilization that was presented by Dr. Church, I would like to say that in best case scenario, when we're comparing the resources in the mom and in the baby, it might be those results. But we also have to keep in mind that the preterm induced delivery that we might have with fetal intervention can also have some economical consequences on the families. Being in the NICU for 10 weeks, 15 weeks definitely has an additional cost than those babies that are born at term, and having potentially neurodevelopmental delays related to extreme preterm birth can also have some economical consequences in the future of these babies that might be underestimated. Also, if the mom develops some very significant morbidity, it can have an economical impact as well. So I would like to stick to the line that we should be strict in the indications of the therapies that we do in utero, just because we know the risks, we know the benefits, and we should work under the studies that have been published with a high level of evidence. Thank you.
Thank you very much, Magda. Can I ask Paige also to make a 5 minutes rebuttal, maximum 5 minutes, I mean?
Great, thank you. I think the first thing I'd like to say is that certainly when evidence is available and it is strong, it is ideal. And there's no question that that would be the case. In the NICU, where I work most of my days, there are a lot of things that we do and we don't have great evidence. And that's partly due to the nature of neonatology and pediatrics. It's a lot harder to do clean trials and have absolute evidence with babies that have so many incredibly important variables that change their outcomes. So while I would like to say that I recommend that we follow the evidence, in this situation, we may not have the evidence. And in that situation, what there is strong recommendations and evidence for is shared decision-making as the ideal approach for families. So acknowledging that there isn't great evidence and having that important discussion and saying, we don't know. And these are the potential risks for the mother surgically. These are potential challenges for the child in the future. These are the potential economic impacts of having a child like that, the familial impacts, who's going to take this child to school? How do you get the child on the school bus when the child's in a wheelchair? Do you have a house that can accommodate those things? I mean, these conversations can take hours and they are incredibly important to have. But at the core of it is that the family has the right to participate in a shared decision rather than having the decision implemented to them or on them. So that's situation, or that's point number one. Point number two is that, yes, I don't recommend that we do in utero closures on cases where the evidence and the data that we have available for this specific case doesn't demonstrate that there will be a benefit to the fetus with the intervention. So for example, if the ventricles are already measuring significantly enlarged, like profoundly enlarged, where a shunt is going to be indicated postnatally regardless, I don't necessarily see the benefit because that is the most obvious benefit of the mom's trial. But there are many other findings where the neurocognitive impact is a lot less clear. Again, being very honest, we don't have the evidence for this. I don't know. This is the range of possibilities. And having families make that decision with the physician, I think, is far more valuable and far less, far more collaborative than just telling them that it's not possible because we don't know. In terms of preterm birth and the economic impact, I agree. I live in the land of prematurity, and when the mom's trial came out, one of my greatest concerns was that we had, compromised one outcome for another, and we had gotten rid of shunts, but we had brought in now a whole host of children that were born premature, and were we going to see a neurocognitive or a behavioral phenotype associated with that? I think Houtro's study at 10 years is important data, And it was surprising data because it did not show that these children that were being born early showed significant functional impairments compared to their term colleagues. That can be viewed as disappointing because the prenatal versus the postnatal did not demonstrate a functional outcome that was different. But they did demonstrate improvements in independent ambulation, which is again specific to spina bifida, not prematurity. So what I think is important to note is that on intelligence tests and on functional tests and behavioral aspects, these premature children, and that is where they present, is intelligence and behavioral regulation at 10, they did not present as different. So we have fairly good school-based data that suggests that prematurity was not a significant morbidity for these children. I agree that we need more, but certainly it is promising, and my children will definitely present by school. And lastly, I think that whenever we have a situation in medicine where we don't have great answers, but it's the case before you, medicine is clinical. It's decisions based on the best evidence we have, but it's also the decisions based on the complex array of conditions or situations that this family is bringing to you. And research is where it should be generalizable, not necessarily the clinical case. And for anyone who has been a patient in the medical care system, the last thing you want someone to say to you is, we can't do this because I don't have the research. People want the information and they want the evidence, but they also want to be empowered to make a choice that's right for them. And I don't think that we should take that away because we're concerned about inflicting risk or harm on them, if it's something that we don't know and we're not sure of, and they're willing to take that chance. Thank you.
Thank you very much, Dr. Church. And once again, also thank you, Dr. Sanz-Cortez. I think the ISPD headquarters will now first launch a new vote. Again, this is not a popularity test. And please use the voting system. And by now we have already 160 people participating in this debate. This is what we call a steady state, or almost, I would say. And I think thank you. So we have seen an effect here. I mean, it is definitely a change in opinion. I have not done any statistics on this, but I don't know whether it's significant, but certainly relevant, what I saw. I would like to wrap up now, first of all, with thanking the speakers. And I will launch the closing remarks. So what did we do with the case that we were presenting? Well, we did operate on the request of these patients after very deep discussion also with the multidisciplinary team. We had an ad hoc positive advice of our ethics commission who reasoned that this was an additional condition with a benign known natural history, amenable for good functional postnatal repair. And they reasoned also that the condition on itself was definitely not compromising neither the outcome of the spina bifida, neither its surgery. And on the other hand, the fetal surgery itself would also not compromise a functional repair after birth. So therefore, we operated in 2014, as I said, and we are now a few years later. The baby was born at 35.5 weeks. We got very nice letters from these parents every year. And so by 2020, this baby is still doing quite fine. It's ambulating. It doesn't have a shunt. It has had its subsequent repairs for the cleft lip. It goes to school, but it is slightly mentally retarded. I must say that in fetal surgery, we are permanently exposed to this dilemma. And when we look back now in the last 4 years, since certainly for spina bifida, we have seen there has already been a practice variation. We have extended the maternal indications. We operate on well-controlled diabetes. We have moved up the limit of maternal BMI. We have even now case reports of patients that had active or infection, or patients that had histories, obstetrical histories, or a history of, for instance, inflammatory bowel disease. And we have also already played a little bit with the criteria that were purely fetal. I mean, how far do you go with subtle abnormalities found on intracranial imaging? And also, as I mentioned, structural anomalies are sometimes accepted. So I think indeed we are doing these type of surgeries. We may select our cases very well, but indeed they should be reported, they should be registered, and perhaps for these very uncommon indications, we can build up a certain experience and that we can learn from each other to know what the combined outcome of this condition and surgery is. I would like to finish with some parental thoughts. We recently completed a study, an interview study with 24 consecutive parents on their thoughts about fetal surgery for spina bifida. And these patients were interviewed before and after surgery and 6 months after birth. And what we heard as a constant from them is that they perceive fetal surgery really as an opportunity that needs to be taken. For them, very often it means the only option for them to modify the natural course of this condition. They do this and are mainly driven by a feeling of parental responsibilities. They do say they are very well aware of the risk and the uncertainty about the individual outcome. Their expectations are overall quite realistic, but we must admit they're always driven by the hope for the best outcome. None of our patients has expressed any decisional regrets at any stage, including even the few cases where there were disappointing outcomes, prematurity problems, very early shunting, etc. So I think those parental comments for us are at least a very important element in making a shared decision to proceed with surgery, even if it is just next to the boundaries defined today. I hope you all stay safe in the next few weeks, and I hope you join us in a week's time for another virtual education series debate. Thank you very much and have a good evening or morning or whatever it is for you. Bye.
Thank you.
Thank you.
Bye-bye.
Thank you.